Good evening, everyone. I'm Dr. Kanisha Zimmerman from Duke University. On behalf of the ABC Science Collaborative, I am pleased to welcome you to the COVID-19 in the Classroom webinar series. Tonight, we'll be focusing on schools and COVID-19 infection, what we now know. As usual, I'm very excited to share the stage here with Dr. Danny Benjamin, and then we'll have Dr. Akamboya present some data to you, and we'll have a session of questions and answers. Danny?
Thanks, Kanisha. So as usual this evening, thank you for joining. We're going to take questions from the comments section, and we will supplement our presentations with your questions. We'll have a brief presentation followed by live Q&A. Questions that aren't answered during the webinar, we are collating those, we're combining them with other questions. Questions tend to repeat themselves, so we'll have a frequently asked questions on the website, and we'll have a repeat of frequently asked questions in a future web. The closed captioning for tonight, please use that function in YouTube. And as usual, the webinar slides and videos are available on the website. Back to you, Dr. Zimmerman.
Dr. Akamboya, we'll get started.
Yeah, so we'll jump right into it. As Dr. Zimmerman mentioned, welcome everyone. We're going to start off with some of the context slides on topics we've previously discussed, and that should help set the foundation for us shifting to talking about COVID-19 in schools and COVID-19 infections in schools, which is really what our focus is today. So just briefly reviewing again, COVID-19 transmission is primarily spread through respiratory droplets. And what that means is thinking of raindrops around that do drop to the ground. They are produced when someone coughs or sneezes. If it lands in your mouth or nose, or it's inhaled by a close contact, you can spread the infection. Of course, just by spewing into the air, there's the possibility that surfaces can be contaminated. And if you touch it in the moment that sneeze touched that surface, you could potentially get infected. But this is not a major way of transmitting the infection. And finally, the key difference here is that from some of our other respiratory viruses.
Yeah, it'd be like a stalker and a frozen.
Yeah. So like
12 hours, that's not bad.
Something to do.
Yeah. So.
Can we,
I gotta go.
yeah, Kath, we've got one of the superintendents, I think, who may need to mute themselves. Thanks.
Yes, thank you. And so finally, I think the key difference we've often said with this is just the fact that transmission can occur from people that don't have symptoms, which is different than a lot of the typical respiratory viral infections we've discussed prior to COVID-19. Next slide, please. Again, this is a slide we've shared before. This is not created by us. This is a great slide that just puts some of the recommended precautions in context. So the key message here is the concept of preventing COVID-19, particularly in schools, but really in our community, is keeping the Swiss cheese model in mind, where each layer acts as a preventive barrier. If you line them up properly, those holes should not align, and you at the end should not get COVID-19. But it does involve physical distancing, ventilation. I mean, we've talked about that. We can talk about that again today. Using masks, washing our hands, and then having access to testing so that if someone is symptomatic, you can get a test that works and you can get that result quickly enough that we can perform contact tracing, and of course, making sure we clean our environment and clean surfaces. One intervention by itself may not be perfect. So each intervention can have holes. Either you're not distanced enough, you take your mask off or something, but multiple layers improve success. Next slide, please. This is an article that came out this past week, and we're not trying to belabor the point here. Again, we try and review the data and show the data to ensure that we're all on the same page as we head into our Q&A section. And the reason why we included this here was that it was to address the questions that continue to persist about the use of masks. And the authors here did a great job in just kind of summarizing. So to be clear, I'm just going to rephrase what they said. So to be clear, the science supports using masks to prevent spread. And recent studies have suggested it could save lives in different ways. So specifically, they cut down on the chances of transmitting the virus, if I'm infected, spreading it to other people, and also catching the virus from somebody else. So the amount of droplets that get to your face, that land on your mouth and nose, the amount is reduced and potentially can reduce the severity of your illness if you do contract the disease. So the goal is it prevents you from getting the infection and spreading the infection, and also might reduce the severity. So masks work, or face coverings. Next slide, please. So now let's switch gears to what we're here to talk about this evening. So what do we know about transmission of COVID-19 in children? Next slide, please. The CDC has pushed out a lot of information around transmission in kids. This is one paper that's particularly helpful because it summarizes a lot of the papers that have talked about when and how you find a virus in a child. So as we all know at this point, you can be infected, you can shed the viruses for a while, so viral fragments, and you may not actually be spreading the infection after your 10-day period. So that's why we have the 10-day isolation. What this summary paper is saying is that children, so symptomatic neonates within the first month of life, children and teenagers, they can get infected and they can shed infectious virus, so they can spread the infection. That's fact. However, even though we know that children who are infected are infectious and can spread, it doesn't seem to fit the model that children are the main drivers of community transmission. And what that means is when you look at who's been in contact with an infected child or look at places they've been, they don't seem to be the major super spreaders or the ones driving the infections in our communities. Next slide, please. However, there are many more studies that come out from other places. So this is a paper that has been shared often last week that's just talking about trying to address what exactly does it mean that children can get this infection but can't spread, and what does all this mean? This paper came from 2 Indian states, so different country, and they were looking at their data in terms of epidemiology. So who's getting this infection, how old are they, what's their demographics of gender, sex, and what's the transmission dynamic here? So are they spreading it to each other or spreading it from kids to adults or adults to kids? What they found is that as compared to the United States, cases and deaths in India are seemingly concentrated in younger cohorts. The Indian population is younger than the United States anyway, and for them, what they found is in the US, we're worried a lot about people that are over the age of 60, 65. Here, they found that the numbers of infections dropped precipitously after age 35 to 40. That's much different than what we're seeing in the United States. However, the infection probabilities were a bit higher, particularly for low risk and high risk contacts. So if I'm infected and I have close contacts, what are the chances that a close contact will get infected? And that was up to about 10%, particularly for the high risk contact. So close contact less than 6 feet. And what they also found is that the highest risk of infection occurred when you had contacts of the same age. And this is actually similar to some of the emerging data in the US. What that means quite simply is kids are more likely to spread it to kids in their age group or say a sibling as compared to an adult. And they also found that. And interestingly enough, they also found that no secondary infections occurred in up to 71% of cases. What does that mean again? Quite simply, if I'm infected, the number of people I can also infect will count as a secondary transmission. And they found that despite seeing a number of cases, 71% of cases did not have a further spread, which is somewhat encouraging, but we're still extremely worried about the last 29% that happened to spread and spread very quickly. So in summary, this is slightly different from what we've seen in the US data. It reflects what we already know. Kids can get infected, they can spread it. In India, it tends to be in age groups that are closer to theirs, so they spread it within their own age groups. And in India, as compared to the US, people over the age of 30 to 40 don't seem to be as infected at the same pace as those that are younger. Next slide, please. So what's happening in schools, shifting from just talking about children in general to schools. Next slide. We're going to go through, before we get into some data around schools, particularly what's happening in North Carolina, we want to just talk about what has happened across the nation. And thankfully, again, the CDC has helped with summarizing quite clearly where the infections are, how they come in, and how they spread. So this is a CDC paper that looked at transmission of COVID-19 outbreaks within childcare facilities in Utah. And they were looking over a period where there was high community spread, so April to July 2020. And I'll just walk through the table very briefly. You can see in the picture on my right, looking at the screen, that children, the summary, the take home from this was that children who are likely to get COVID, who likely got COVID-19 from a childcare center were able to spread it within their households. That by itself is not surprising information. We know that. We know that kids can get infected and can spread. The goal is to ensure that as much as we can, we're preventing infections wherever that might be. But going back to what actually happened within the childcare settings. So there are 3 key facilities they looked at here. The first column is looking at what were the COVID-19 precautions in the facilities. And you can see at least 2 of them had masking for staff required. 1 facility did not, or they had it as optional. In each of the facilities, the index case, so the first identified person with COVID-19 that came into that school or daycare environment was an adult in each case. Unfortunately, each of the facilities did not require masks for children. And as you all know at this point, children can wear masks, they can wear it safely. We do need to talk through how can they take mask breaks? Are you sure they're going to be compliant? Will they become a behavioral issue? But they can wear masks. And all the facilities were not distancing 3 or 6 feet. And unfortunately, again, the adults that were the index cases were already exposed. At least one of them did not know about the exposure until after they had already come to work. But we had cases where people came to work while sick or exposed. They all had temperature screening, they all had some type of symptom screening. It's important, but like the Swiss cheese model, those things are not enough to prevent spread within a childcare facility. Next slide, please. So on the counter end, so that's what happened in Utah. The CDC also went through and reviewed cases in Rhode Island. And this paper was just reviewing what happened in similarly childcare settings that were open during the peak of the pandemic. On the graph to the right, you can see the y-axis is showing the number of cases, x-axis is showing just time. And as community cases increased, the cases in schools or childcare settings increased. So in Rhode Island in particular, they saw cases in about 29 programs. 20 of them, so 69% had 1 case and no secondary transmission, no spread. But there were about 4 of, even larger number of programs, 4 of 6, the 666 programs they looked at that had secondary transmission. Really low, but it's possible even in the best case scenario. So most of these places had masking involved in their precautions and also distancing. But all of the transmission that they saw occurred in the last 2 weeks of July as they were seeing increased community spread. And it was called possible transmission because sometimes it's hard to know if this was exactly from the school, but it was attributed to the school or childcare setting. So when done well, you can have 0 to minimal cases of secondary transmission, even if you see cases among people that attend schools. But remember, community just reflects schools. Schools reflect the community. If we have cases in the community, we will likely have cases in schools. The goal is to make sure we've set up protocols that prevent spread in schools. Next slide, please. And this is just going through, so we focus a lot on the US. We have data from outside the US that is somewhat more robust than what we have in the US. They've been open for longer. They managed the pandemic somewhat differently from how we've done in the US. And we've shown this in other settings, but just briefly walking through what this paper summarized. So in China, they had about 68 kids over the peak of their pandemic. When they looked at who exactly got the kid infected, about 96% of them had a prior adult contact. Again, doesn't negate the fact that kids can spread this, but it seemed early on in the pandemic, kids were getting it from adults. Probably reflects what we're doing in our community. Everything was shut down. However, in France, on the other hand, they had opened schools back. This 9-year-old had multiple viruses, so had COVID-19, had influenza, had this pico-RNA, it's a small RNA virus, and had multiple contacts at different schools, but did not spread COVID-19 despite successfully spreading influenza. And then in Australia, similarly, again, 9 students, couple of staff members, multiple contacts across different schools. Kids can spread, adults can spread, despite numerous contacts, over 700 students, only 2 secondary infections were noted. So low rates and low numbers. Next click. And the point being, so just go back one slide, just to finish out that slide. So the point being, SARS-CoV-2 in transmission in schools may be less important than community transmission, and just somewhat different from what we initially feared. So next slide, please. So switching now from global setting back to the US, everyone's been asking, we need data. We need to know what's happening. We need to know what's happening in schools that are already open, how they're open, and what it means. And because a lot of our efforts around COVID-19 have been state-based, it's actually been more difficult than we anticipated to get data from the country as a whole. However, this professor, Dr. Emily Oster, has spent a lot of time crafting this website. There are some limitations, and there are many ways you can question if the data truly captures everyone, but it's the most robust that's out there, and it's over 500,000 kids. And in summary, what they found, this is from this past week, looking over the last just about 8 weeks of schools across the nation, is that schools are not the major spreaders of disease. That doesn't mean that there are not precautions that need to be taken, or that we need to sort of throw everything out of the window and just do whatever we want, because they looked up 200 kids in 47 states, and there are still infections. It's low, so the infection rate was about 0.13% among students and a little bit higher among staff. But the nuance here is the infection rate was the same or lower than community rates at each place they looked at. And when you look at the tinier periods over 2 weeks, it's about 1 infection or 1.3 infections over 2 weeks in schools of about 1,000 kids. So as you think through your school district, your particular school, it just helps with anticipating what could be expected and having protocols in place to address them. Next slide, please. I'm going to hand over to Dr. Benjamin here to just kind of walk through what about the clusters and public school, within public schools in North Carolina. And just as a reminder, these are all publicly available data that's been shared by NCDHHS. So just double checking, because then if you're speaking, I can hear you.
Great. So these data as mentioned are available on the website for a DHHS, and it's are you able to hear me? Can you hear me,
Yep. It's better now. Yep.
Okay, thanks. So just as a reminder, and Ivakin, if you just, I can see your screen, so just touch your ear if I come in and out, if you would, for me, please. But not your face. The clusters in North Carolina are defined here as 5 or more cases that are linked to each other by a local health department. 5 or more cases within a school linked to each other. Now these are by county, listed by county here. The black line represents a breaking point. The schools above the line are outside of the North Carolina Collaborative, the ABC Collaborative, but are in North Carolina. The districts below the black line are in the Collaborative. These are a mix of high school, middle, and elementary schools. And these represent, from across the state of North Carolina, approximately 500,000 children and staff who have been in school over the last 9 weeks. The Just to give folks an idea of the size of these school districts, the county of Craven or the district of Craven, less than 5,000. In between 5,000 and 10,000 students are Sampson and Wilkes. Greater than 10,000, we see a handful of those on this. Now again, this is from over 500,000 children and adults that are in hybrid instruction over the first 9 weeks that the buildings have been opened. You can also see over to the very far right-hand side is the population of school children in thousands in these particular counties. Again, most districts had 0 clusters throughout the state. Approximately 50 school districts across the state were open throughout this time. A little bit more than that, perhaps. So you can see that most districts had 0 clusters. There were 13 clusters here total. Most of these, they were evenly split between the number, approximately evenly split between the numbers of staff who had positive tests and the students. And again, this is hybrid method of education since mid-August. Now you can see that this represents about 47 students, 39 staff. Now for the districts that are in the collaborative, whenever they have several cases, we get on the phone with the staff in the collaborative and we do a lessons learned with the participating school district. For example, we had one school district that had several cases. That's not necessarily represented on this slide, but they had several cases where they were realized that they were not requiring their children in the pre-K program to mask. At that time in August, that was consistent with state guidance. We talked with that school district about it, and they quickly decided to move to requiring all children, regardless of age, to wear a mask all day long. Next slide, please. So this is a story really about a successful school district. And although these data are publicly available, we've blocked out the names of the school because there's so few cases. We don't want to call any particular school or have any potential for identification here on this call. These data are publicly available on a school district's website. And this shows in a very busy slide the number of cases at each school in this particular district. So this is a fairly large district. There's more than 20,000 students and a total population of students and staff of over 30,000 in this district. You've got a school district here that is about 50 schools in total. Each line here represents a particular school. Each column represents a week. This is through the first 8 weeks. You can see that most schools have no cases during a particular week at their school. Then you can occasionally see 1 or 2 cases at individual schools. Now, throughout the entire quarter here, many schools had 0 reported cases. There were 15 of those. Most schools had 0 secondary transmission at all. You see another 20 schools there had 1 case. Several of these schools that had 2 or 3 cases, the cases were separated by weeks apart or were otherwise not linked epidemiologically. You did have a handful of schools that had 5 or more cases throughout the quarter. But keep in mind that even at this school that had 9 cases during the quarter, this is a school where that represents 1 less than 1 case per 1,000 students per week. And this school in total had fewer than, this school district had fewer than, much less than 1 case per 1,000 students per week of hybrid instruction. This is a really successful school district in the first quarter. This is a testament to adherence to masking, its adherence to distancing, it's in the hybrid instruction environment, and to hand hygiene practices. Go ahead, next slide, please. I think it's back to Dr. Akamboya. Akin, I think you're up next.
Thank you. So how can we make all this work together? What exactly are the next steps? And I think these are things you're already thinking about, you've been thinking about for weeks to months, and the AP summarized them clearly in this document, which I think has also informed the NCTHHS document and all of the district policies. And one major thing, we've all had to learn this, even in a healthcare setting where we would like to have a lot of structure. And I know educators are probably one of our most structured groups with all the planning ahead that has to happen. But COVID-19 has forced us into an era where we have to be flexible. We have to be flexible with resources, with plans, as long as the core content of preventing infection is embedded in the plan, we can be flexible as to how it actually happens. We need data, we need to use available data to inform our decisions. We should adjust decisions and adjust protocols based on local viral transmission. If we do start to see skyrocketing rates, there is no perfect number. I think a trend is what's important. If we're trending downwards, all of the plans that are in place can continue. If we go back to March where rates are skyrocketing, no one knows what's going on, all the hospitals are full, then we may need to just readdress plans as needed. Plans should be practical and feasible. And as much as possible, we need to limit excluding children. Once we get to a point where we're educating more children in person, we need to create plans that limit the exclusion of children, regardless of their level of development. And so trying to incorporate plans that have special needs, exceptional children, and all of their needs incorporated into the plans will be important. So let's not forget kids with special needs and behavioral health. Next slide, please. I think we're going to kind of switch gears here. I'm going to hand over to Dr. Zimmerman and try and see if we can get through a number of questions that have come up, either related to the presentation or otherwise.
Thank you, Dr. Akamboya. I think actually there are a couple of questions related to the presentation, and so let's start with those. There is a question about the cluster slide. This goes to, I guess, to Danny or Dr. Benjamin. Have they all been in school at the same time?
So most of the schools that are in hybrid have been open in hybrid since August, but several school districts a couple of school districts will open per week. And that's continuing throughout this month and will, from what we understand, continue throughout next month. But I would say approximately 50 were open in mid-August, between the 17th and the 24th. And then it's been a couple per week added on since then.
Great, thank you. Dr. Akamboya, there's a question about Dr. Oster's work and what age groups were studied within that, the Atlantic Guard.
Yeah, so full details are available on the website at the end, and we will have that after the webinar. And it seemed, based on my review, that it went from elementary, so about 5, so elementary school age, all the way through high school, so maybe under 18, give or take. I don't remember if age was particularly included in all of the summary data. I think classes, grades, and maybe classroom sizes, but I would have to go back to know what the spread in age was.
Great, thank you. Dr. Benjamin, I think there was another question about what's happening in the community with regard to the districts. So is the community spread increasing, decreasing? What's happening kind of in the community around these clusters and around these districts that we've been talking about?
Broadly speaking, the school districts where there's clusters are relatively representative of the state as a whole. There was, if you look at just one particular metric, say percent positive cases or total number of cases per week. Let's look at that one. If you look at total number of cases per week, they're broadly stable compared to the rest of North Carolina. You saw this increase in the summer, then kind of a dip down, and then a dip back up. So as Dr. Akamboya said, the schools very much reflect the communities, and likewise, the school districts are in counties, and counties typically reflect the broader state. Now, the school district in particular, where the detailed data were given as a successful school district, that school district, again, has been relatively stable. They had a little bit of a dip in August and the first half of September. They have a little bit of bump back up in the second half of September that we also saw here locally. Some have speculated that was maybe linked to Labor Day weekend. And the percent positives in that district for the most recent week available is right at 10%. And it is a reasonably consistent finding in that particular county. So in some sense, the people who are spending a considerable amount of time in school are perhaps in a safer environment than the people outside of school, which is not a surprise given that the compliance with masking in these public schools is very, very high.
So just wanted to add one thing there. A great summary there, Dr. Benjamin. I think the other point to note is that the opening and closing of schools in our local areas have not been associated with increase or decrease in transmission in the county. So even when we see clusters in schools, we don't see a massive spike in the rates. If rates are spiking, you can see that across North Carolina. It may be associated with the recent holiday, some longer weekends, or big events, and it has not been in districts where we have a lot of data. It has not been associated with the clusters in schools.
Thank you very much to both of you. Dr. Akamboya, I'm actually going to come back at you with another question kind of related to that. How much of the low spread among or between children is due to limited experience with children? For example, many schools aren't open yet. Parents have protected their children and not allowed them to be out as much.
Yeah, so some of the early days, March, April, a lot of the low numbers we saw were likely because we were not testing children, and children were just not in their usual environments. They were not out and about. I think partly why we showed data from other countries and showed the most robust data we have to date that captures the nation is that we now have more experience where children are back to some relative normal schedule in other places, maybe not so in the districts here in our state, but in other places that have done this, that have comparable rates of transmission in the community or even higher. So Georgia and Florida have done this a different way. I don't know that we all necessarily need to do it that way, but even in those settings, we have not seen massive spikes within the school setting, which I think is worth learning from.
Thank you. And then just another question that is, I think, related to your talk today. Students under the age of 22 can be termed super spreaders of COVID-19. Can you elaborate or dispel this with research-based answers? Maybe going back again to what you talked about earlier today?
Can I clarify the beginning of that? Did you say children under the age of 20?
22.
I'm not sure where that came from. I think super spreaders can be of any age. And it tends to be similar to what I mentioned earlier. So what data has shown is that the percent of people that are driving this infection are much smaller than the people that get infected and just do fine. So like the Indian data where they said 71% of people did not actually lead to further spread, but then there was the extra 29% that likely spread. But super spreading events can occur, and you can have one super spreader, so one person that leads to massive number of cases, say for example 50 cases. Can it be a child? Yes, it's possible. However, when we've seen super spreading events, most often it's related to an adult in an environment than a child in the environment. So I don't think there's any research that suggests that children less than a certain age are the ones leading to super spreading events. That being said, we have seen super spreading events on college campuses, and I think it's because the environment there is quite different. Overnight stays, younger, so youth, I guess, more older kids, but younger adults, and relatively inconsistent mask wearing in closed indoor settings led to super spreading events. So very different from expecting all kids, particularly those less than 18, to be super spreaders. The data does not suggest that at all.
Thank you. Maybe one for you, Dr. Benjamin. When students return to the classroom, are there data that support the use of continuous cleaning of door handles, desks, computers, etc., reducing the spread within the school community?
The data there are pretty limited. This is the concern that COVID-19 can be transmitted via fomites. That is, I touch my face, I touch my iPhone screen, somebody else comes along, touches my iPhone screen, touches their face. Okay, that's fomite transmission. Although that transmission is limited, the groups that are having success right now are having success with a combination of more frequent cleaning, more frequent hand hygiene, masking, and distancing. And I think that the data supports staying the course on those principles until we get additional information. Fundamentally, this is a respiratory virus. This is going to be a respiratory spread. That's where most of the transmission is going to occur. But we need to keep our environments clean. It's not a bad infectious disease practice. And while we're still in the early stages, this is not the time to relax based on some very reassuring early data, extremely reassuring early data from not only 500,000 children in North Carolina in school, but also millions of children in school throughout this country, let alone the globe, where children are as safe as it relates to COVID as it is in their community, or safer, and that the adults in the work environment, provided that there's masking, distancing, and again, most of our data is from the hybrid environment, are safer or as safe in the work environment. It's too early in my mind to be changing or moving away from regular cleaning.
Dr. Benjamin, related to that is another question about a news story with a study that suggested that COVID can remain on non-porous surfaces for up to 28 days. Is this true?
Well, there's a difference between being able to isolate genetic material, and remember that these tests for PCR are exquisitely sensitive and are able to pick up genetic material from viruses that can survive. That's the next level. And then viruses that can survive and infect another human being. And quite bluntly, if COVID-19 were regularly transmitted via 28 day contact, the pandemic would have been over in August because we all would have gotten it. So anything's possible in medicine, but I would be a little hesitant to be concerned about a prolonged time of the virus on a surface.
Also supports what you said about cleaning, continuing to.
That's correct. Thank you for that, Dr. Zimmerman.
So
Kanisha, before moving off that point, just one other thing. So there are some studies that artificially place the virus on the surface, keep it in almost hibernate that surface for a while in perfect conditions, and then continue to swab for days on to see how long they can continue to find the virus. That's an artificial setting. That's not real world setting. And we would not expect the virus, even if you can find it after 7 days in the lab, practically speaking, we don't see that in reality. And there've been 1 or 2 papers that have said in real world settings, when we swab things that people are using every day, cleaning frequently, and touching, even if it's a door handle or something, we're not seeing the virus survive as long as has been reported in the artificial lab setting.
Thank you, Dr. Akamboya. One additional question for you. You mentioned that COVID-19 is spread by droplets. Why does the CDC keep talking about it being aerosolized?
It's a fun topic. We had an hour, I think, to discuss this also previously. So the major way of spread is through droplets. And what that means is someone is expectorating. So you're spewing out drops into the air. You can also spew out tiny enough particles that travel further. Or if we perform a procedure on someone, so it's not just a cough or a sneeze, if we put a tube down someone's throat, you could release tiny enough particles that can travel further. So they don't drop like a raindrop immediately you release it, they hang in the air for a little bit longer. And that's what we're referring to as aerosols or airborne transmission. But that's not the major way of spread. It is possible, and it has been, when you look at how the infection spreads in some setting, it clearly spread to someone that was not within the space where a drop would have fallen. And so to me, it supports the fact that airborne transmission is possible. But this is not the major way of spread. If not, again, similar to what Dr. Benjamin said, a number of us would already be infected because there's only so much spacing you can do in a grocery store or something like that. And airborne infections move very quickly, such as measles, thinking of Disney World prior infections, those spread a lot faster. It's possible, not the major way of spread. Highest risk is coughing and sneezing and droplet, and we need to do a lot more to prevent those. But certainly having standard scheduled maintenance of ventilation systems and moving lots of things outdoors if you have to be with people will be helpful to prevent airborne spread.
Thank you very much, Dr. Akamboya. So Dr. Benjamin, you have been talking a lot about it being safe for children in the building, but I need to hear something about adults.
Yeah, so clearly the highest risk population is the adult population. So all of the policies and all of the procedures that we put into place have to rise to the level of protecting the adults in the building. That's job one. If we provide for a safe work environment for the adults, and we enforce those same policies for the children, protection for the children will follow. So paradoxically, although most of the population in the building are younger humans, it's actually the humans over 18 that we need to drive to seek to protect the safe work environment. And that's the standard that must be achieved. It's got to be achieved for several key reasons. Number one, if there are no adults in the building, there should not be any children in the building. Number two, if we are harming people in the work environment, that is completely unacceptable. And number three, if we protect the most vulnerable, we will be able to protect all. Now, those are not said in a rank order of importance, right? You might say those entirely the other way around if you had to say them in rank order of importance. That's number one. Number two, we are seeing a few more cases than, if you look at clusters, there tend to be more adults involved than children. And in talking to folks who work in the school districts, it appears as though compliance may be higher in younger folks than it is in the adult population. We don't have data, scientifically robust data to support that, but it looks like that's at least possible given the relatively high number of adult cases in the clusters relative to the adult to child ratio population in the school district.
Thank you. Let's see, Dr. Akamboya, is there a way, if exposed, to cleanse the sinus cavities?
I'm sorry, what was the question? Just to make sure I understood.
Sure. If you were exposed, is there a way to cleanse the sinus cavities to prevent getting infected?
Oh, got it. I missed the beginning part. I just heard the cleanse sinus cavities. I figured before I go down that thread, I should clarify that question. So if you are exposed, what can you do to make sure you don't go from exposed to infected? Unfortunately, right now, we don't know. Other than there are quite a few people that are exposed that don't become infected. We think somewhat is related to the type of exposure. Maybe they were not as close, maybe they were wearing a mask, maybe they washed their hands right afterwards, but there is no procedure that you can do that will prevent that. So there wouldn't be any data that I've seen to suggest that cleansing the sinus cavity would help. Remember, these are tiny viral particles. As soon as they almost touch a surface, they can embed. And all we're waiting for is to see if the viruses grow or replicate fast enough that leads to infection. And some people, it doesn't, and for others, it does. So I would not do anything extra with your sinuses.
Thank you. Dr. Benjamin, are the clear face shields approved by CDC as acceptable masks to be used in teachers in the classroom? Can we use the clear masks that the CDC has approved?
Yes, so I've seen advertising that represents that there are clear masks that have gone through FDA's approval process. I'm not sure that that's actually occurred. They may have received an exemption for how they did some of their studies or the way that they presented data to FDA. So I don't want to imply that any clear masks are approved by anyone, number one. Number two is the group at UNC has been looking at masks, and they will take up, my understanding is they will eventually take up the clear mask. Number three, because they're not data on those masks yet that have been really vigorously peer reviewed or reviewed by thoroughly by FDA that I'm aware of, until such time, I would reserve any clear mask use to a detailed plan that is put together between the school district, the health department, and the special needs team for a child. For example, the child who really does need to learn by seeing the instructor's face, for example, the deaf and hard of hearing. I would be hesitant to be an early adopter of the clear mask when there are other masks that have been more rigorously peer reviewed as far as those data are concerned.
Thank you very much. Dr. Akamboya, anything to add there?
I concur. I think there've been a few cases where we've, just to give people practical examples. So in my role here at Duke, I've approved the use of clear mask in some of our audiology clinics, and it's been relatively safe in that context, and we've not seen any transmission. But it's not related to any specific brand or anything like that. It's just an option for kids and educators that may be hard of hearing.
Thank you. Coming right back at you. So once infected, how long can a child shed virus prior to showing any symptoms?
So once infected, a child and an adult can start to shed and share their virus about 2 to 3 days prior to showing symptoms. And remember, just restating what I said earlier, some people may be infected and never have symptoms. So to address both things, if you're exposed, preference is to quarantine at home during that 14-day period after an exposure, just in case you become infected and we didn't pick it up, or your symptoms develop on the tail end. If so, you can spread the virus in the first 2 to 3 days before you show symptoms. After symptoms start, for the most part, most people stop shedding live virus at about day 7. So if you count 10 days from symptom or positive test, that should be more than enough to take people out of isolation and reduce the risk of spread once they're past that 10th day. So that's where the 10 days comes from.
Thank you. And a follow up to that, what has been the role of asymptomatic children in the spread of disease so far?
I think the role has been significant in the sense that children have had milder infections and are more likely to be asymptomatic, and they can also spread. There are numbers that have been passed to. Some people say asymptomatic spread in kids, probably about 30 to 50% occur in asymptomatic kids or kids with mild symptoms. So I do think that kids play a portion in the transmission from asymptomatic people. However, as a whole, kids are not the major drivers of transmission. When put together, in a household even, it's more likely that the kid may spread to a sibling as compared to an adult, and it's more likely that an adult brings the infection into a household, even if both the adult and a child had the same exposure.
Sorry, one more question, just as a follow-up.
What am I here for?
How long can an adult or child carry the virus before displaying symptoms?
Yes.
How long?
How often, you said?
How long? How long?
So it's easier to answer the question if there is an exposure. I think without an exposure, if you're just going about your day-to-day life, it's hard to know. Most often, it can be between about 2 to 5 days before symptoms start, and you can spread it in that period.
I lied when I said that was my last question to you, and this is just a follow-up to before. So you talked about the things that you might be able to do to reduce risk of infection, or actually that there's no evidence necessarily that there's to reduce the risk of infection after being exposed. So let's assume there is a risk of COVID infection. Should we change our clothes once we get home and shower to reduce our risk? Is that something we should be doing here?
So I see COVID patients in the hospital every day. Because in my role as a consultant, I don't always need to wear scrubs. I don't. And on my return home, I just go ahead and sort of change as normal and put clothes in routine laundry. So I'm speaking from personal experience because I think that's the best way to address that question, which is if you've been exposed, clothing is not the major source of spread. It would be your hands. And certainly if you were in a mask that now has a splash on it, or your face covering or your shield, changing those and cleaning those would be probably the most likely thing to do. And if you were wearing a gown, sort of a gown covering or gloves, changing those are important. But just actual clothes that can soak in droplets, it kind of soaks right through and it's not the major form of spread. But I'm a big advocate for ensuring that you're washing as you transition from a setting where you could have been potentially exposed to, say, home setting, just washing hands and cleaning your environment is important.
Great, thank you. Dr. Benjamin, are there any enhancements that can be made in ventilation systems of schools, especially the older ones, to improve air circulation and reduce the concentration of viruses and germs in the classroom?
Well, upgrading ventilation, when you are adhering to masking, upgrading ventilation has not been shown to reduce infection or reduce burden of disease. That's number one. Number two, given the success, the resounding success, at least early data of school districts that are adhering to masking, it's going to be very, very tough in the mainstream curriculum to improve on masking. Remember that many of these schools that we're looking at these data also have very old buildings, and these schools are doing quite well. Number three, one of the problems school districts run into when they start to invest in things that are unproven, like ventilation, is it detracts resources from interventions that help. So interventions that help include masking and distancing, put resources in places where we know there's benefit. So put resources, for example, in ensuring compliance. Put resources into staffing a hotline, for example, where anonymously staff can call in to express concerns about lack of compliance around masking. Put resources into adherence to masking compliance. Put resources into reconfiguring spaces so that you're able to ensure distancing. Put resources into ensuring that students can distance while on the bus. If after taking care of all of the items and all of the ways that have been shown through human data, through scientifically peer-reviewed human data, if you've maximized in every possible way the ways to prevent infection, then if you would like to speculate on ventilation systems, by all means, that's warranted. The one exception to that, and this is, I can see, a wise use of ventilation or seeking in whatever way that you can to improve ventilation, is when you don't have the ability to mask. So for example, what in Chapel Hill we call the adapted curriculum, what in Wake County is called the regional curriculum, the kids with special needs, where they physically cannot mask. Okay, now the whole risk-benefit equation around ventilation, all that changes. And now ensuring the protection of the instructors and the adults caring for those kids who can't mask, all of that becomes really, in my mind, an important thing for a school district to consider.
Thank you. Dr. Akamboya, if you get the virus one time, can you get it again?
Yeah, so we're seeing, I don't know if this is good or bad news yet, but we're seeing some information that yes, you can get infected again with the virus. And this then just brings us back to all the questions around what are we going to do for the foreseeable future? Because now you're not protected just by getting the infection. So all of the public health practices continue to work. We think if we get to a point where there's a vaccine, it may still take us into next year to get the vaccine on the market, but the vaccine should be protective. But right now, natural immunity, so just getting the virus, does not mean you're building up enough protective immunity to prevent you from getting it again, because there have been rare cases of reinfection. It's not common. Millions of people have been infected. We've not had millions of reinfections, so that's encouraging. But I think that word of caution remains. It's possible to get reinfected.
Dr. Akamboya, one additional question for you. We've talked a lot about the risk of transmission among kids and kids to adults, et cetera. We talked about that tonight. Our numbers in North Carolina continue to rise across that demographic. Can you talk a little bit more about how that plays into what we're seeing with the data with regard to transmission?
Yeah, so we've seen an ebb and flow with data in North Carolina. We've seen our rates come down, and then unfortunately in the last 3 weeks, we've started to see it slowly trend up. And as we see community cases trend up, as we test more kids, so now more than ever, we're testing kids regardless of symptoms. If they have mild symptoms, we're testing them. We've broadened all of our testing categories to include even kids that are asymptomatic. So the more we test, the more we'll find, but it doesn't mean that testing is driving the pandemic. It's more that we were not testing as many kids. So the fact that we're testing more kids, we will see more cases. And the fact that we're seeing cases in community would mean that it would trickle down to kids. Based on the data I've reviewed, and I've reviewed a lot of all the way down to granular county level data, it has not suggested that kids are suddenly getting infected more so than adults.
Thank you. And it's 7 o'clock. So that went fast. So we will end today, but the things that the questions that we did not get to will either be addressed in a future webinar, or we will have them in our FAQ page on our website. We are very excited that you chose to spend your time with us tonight, and we look forward to seeing you next week.